I'm really happy to welcome Jay Bhattacharya, Stanford and Brownstone Institute. Nice to see you, Jay.
Nice to see you too, Jeffrey.
And here we are at the last days of the great pandemic panic. Cases are still up. Deaths by COVID are still up, but the country has decided that we're over COVID. So what I wanted to talk to you about today is something that you've written about that hasn't gotten a whole lot of attention. It was a notice on the CDC website, I guess, a couple of weeks ago, that they no longer recommend track and trace for COVID-19, for the SARS-CoV-2, for the coronavirus. And yet it's still going on, right? You hear stories all the time. Kids going to school and, somebody testing positive, and then the classroom forced quarantine. So this is still going on. But I wonder if you could give me a little bit of history of this idea of track and trace, where it came from and how it was used in the course of these pandemic controls.
Sure. So the idea of finding and isolating people who have a disease so that they don't spread the disease has ancient roots. That's not new. It's been used successfully in the past for other diseases. Ebola is an example, a recent example. And it in like some broad strokes, it makes sense, right? So if I can identify people who have the disease and then stop them from interacting with other people in ways that would pass the disease on, you've broken the chain of transmission. You've cut the spread of the disease. In the earliest days of this pandemic, a lot of very smart people latched onto this idea as a way, essentially, to stop the spread of this disease. In fact, I think in the minds of some people, even very smart people, this was a way to actually get the disease to zero. There was an article, an op-ed written by a Nobel Prize winner, for instance, like, we just have to in March or April of 2020, which said, we just test everybody all at once. And if we test everyone all at once, identify who has it, and then isolate them, and we're done. We don't have to worry about the disease anymore.
How does that work in the case of something like Ebola? Because I know that of cases in the past where there have been outbreaks here and there, and then the infected are isolated. And remind me, what is the case fatality rate of Ebola? It's pretty
very high. It's very, very, very high. Yeah. That's orders of magnitude higher than for COVID. And if you get Ebola, you're very sick. It's hard to get the energy, I'd imagine, to go around and spread it a lot. So this is partly why Ebola doesn't spread so much. But it makes sense to isolate someone with Ebola who, if they're feeling well enough to walk around, you kind of want them to not walk around, because it's quite a deadly disease.
And there's a number of pathogens that are like this, right? So they're not circulating, then suddenly they're unleashed, and you can use methods to find the people who have it, get them out of the way of others, and then what happens to the pathogen at that point? Where does
it stop? The chain of transmission stops with the person who's isolated from other people. And doesn't stop spreading anymore. That's the theory and the idea of this quarantining, testing and then quarantining.
And what are the conditions under which it works?
Right. So that's the rub here, right? So COVID has none of those conditions. Let's be careful. Very few of those conditions. So it's let me be very precise. It's missing some of the key conditions. So first of all, you need a technology to identify the person with it, and you would like the technology to also presumably not be too sensitive, also, so that you identify people as having it, but don't actually have it or don't pose any danger to other people just because by dint of having it. Right. So with COVID, we had a test in the early days of the pandemic, this PCR test that's overly sensitive. So the way the PCR test works, it amplifies the RNA, the RNA in the very low parts of the virus, usually the spike protein fragments of the virus, and when it amplifies it, you can infer that the person has the virus in them, right? But that is not the same thing as saying that the virus actually is replicating in you and that you pose any risk of spreading the disease to somebody else. So, for instance, people who recover from the disease often have these viral fragments floating around in them for a long time. These are mRNA fragments floating around. So it's common to see someone who's recovered from the disease to be PCR positive for a while.
But that's a contingency of the testing, not so much the pathogen itself.
Yes.
So you're saying that if we had better testing, that
no, there's more, Jeffrey. No worries. There's more. The testing does matter here, though, because if you have a noisy test, well, that actually greatly increases the cost of this. And I don't mean like money cost. I mean in terms of you now at risk of identifying people as infectious when they're not. And so you impose a 2-week quarantine on them, taking them out of society, their life for nothing, no public health benefit whatsoever. There are estimates that something on the order of, I've seen estimates as high as 60%, but I mean, like 25 to, I mean, a very, very high percentage of the people who were identified as PCR positive and then quarantined were probably not infectious in terms of posing any risk at all of spreading the disease. Okay. Another thing you need is that, this disease, you can get it and spread it even before you know you have it, right? So there's a period in before you start developing symptoms, a few days.
So-called latency, right?
Yeah, it's called pre-symptomatic spread. Mm-hmm. I mean, I think it's 1, 2, maybe 3 days before you start getting symptoms. Okay, well, that means that you most people who don't have symptoms aren't generally going to want to go get tested, because why would they? And so you have to essentially test continuously at very broad populations in ways that actually could actually spread the disease, ironically, right? So I'll give you an example. I think it was Slovakia did a single day where they were going to test like a very large fraction of the population. So huge numbers of citizens lined up together, jostled next to each other, waiting in line to get tested, to identify, be identified. And I mean the disease actually exploded after that. Now I don't know if it's causally linked, but I mean it's just think about the hubris of this. Let's go test everybody all at once. Well, who's going to be doing the testing? Are they positive? You have to go to every single homeless person, I mean, it is not possible with a census to go get everybody all at once. So, and because it's asymptomatic spread, there's asymptomatic spread. I mean, it's you can't just do it once. You do it all the time. Right.
We should say pre-symptomatic spread. There's a difference, right?
Pre-symptomatic spread. Exactly. I mean, if you're so you kind of have to do it all the time, right? And it's this sort of continuous surveillance to try to identify anybody, and with a test that's noisy, that can be positive, even when someone doesn't pose any infectious threat. You can imagine that the level of I mean, just okay. But so that's the disease then is one of these. Ironically, people, when they started talking about asymptomatic spread and pre-symptomatic spread, ironically, people started saying, okay, well, now this is more reason to do this, but it's actually less, because if you have this kind of disease that spreads so easily pre-symptomatically, the scale of the project to identify everyone as positive is so great that you couldn't possibly do it. Now, let me say one other condition that where I think it might be useful, although it's very special, right? So suppose you catch the disease at patient 0. Suppose you know this is patient 0 or very close to patient 0, right? Then you do test and trace of every single person this person's been in contact with the last few days, identify them, maybe do one more ring around that, and maybe you stop the disease altogether.
By isolating them too. And
yes.
And so suddenly the so-called R naught drops below 1 and tends towards 0. And
you like basically the disease spreads by people interacting with each other. So you've got patient 0, You got the ring of people that he was in contact with, maybe the ring of people they were in contact with, isolate all of them or test and isolate all of them, and you're done. The disease has no longer to spread because you've isolated all the people that potentially could have the disease.
It's not eradicated. It's just not present.
It's eradication. It's eradication, right? There you've gotten rid of the disease all because you know who patient zero is, the very first patient who has the disease. And then you know everyone who's in contact with, and there's nobody else he could have spread it to other than the people he've been in contact with. Then you maybe one more ring around that, all the set of people that were in contact with the people he was in contact with, and the disease is now stopped. It has no place to spread because you've isolated all the people who potentially could have the disease. That's a very specialized circumstance. You have to know that you have patient zero.
And that's the most likely scenario is a local area where there's an Ebola outbreak. Any other conditions you can think of?
I mean, like maybe with COVID, the remote Pacific Islands had a shot at this because the disease arrived there in their summer, our winter. And the disease is very clearly seasonal. And I don't think it spreads very well in the summer, at least in those parts of the world. And so they identified their patient zero. They did their test and trace and they stopped it. They got to zero. Now, of course, the disease came back over and over again to those places. They had to lock down over and over again because, this is a very infectious disease and you can't isolate yourself forever, even if you're in New Zealand.
Mm-hmm. And isn't there, I mean, I don't know if you want to get into this just yet because I want to stay on this track and trace over, but it strikes me that what you're talking about here also impacts on the question of immunity, community immunity, and the danger of a naive immune system for a particular kind of pathogens that are so widespread. So probably there aren't people with pre-existing immunities to Ebola, right? Or maybe there are, I don't know, but you don't need that normally, but you might need that to the coronaviruses.
I mean, I think, like we're talking about, but why don't we come back to that? Because that's a different, that's a big topic. Than this. But like, I mean, when COVID arrived, I think basically almost all of the Europe and the Americas were immune naive. I didn't have very much protection against it through some other similar viruses that they'd been exposed to. Whereas I think it seems like a lot of Asia probably was. I mean, it's hard to explain how Asia did so well. But that's different topic. Let's stay on track and trace because there's still more like really important stuff that I think we haven't talked that like hasn't been in common conversation. People should think about it. Okay, so we just talked about like patient zero and small, maybe it'll work in small when you know, but you don't know who patient zero is. When did the disease actually start in the United States? I mean, the official start date was January 23rd or something.
And we know that's wrong. It could have been September 2019, October. It could have been earlier.
It's a fiction. It's almost certainly earlier. And there's a couple of pieces of evidence I can give on that, not necessarily just in the US, but elsewhere. One is that there have been studies of blood donors, blood banks, where you donate blood and they bank it and they figure out that they label the date. And so people have gone back and looked at studies of banked blood from 2019 to look for antibodies to COVID that wouldn't show up otherwise if it was COVID. And they in Italy, for instance, in Lombardy, where it was this hard hit region, they found stored blood from September 2019. It's inconceivable that it was in Italy and not in the United States, right? Because why did we not see a huge spike in deaths? Well, we didn't have a test. We weren't measuring. It would show up as like respiratory disease, pneumonia. Now we probably didn't have a lot of it because the disease, while very infectious, it actually doesn't. It's not like it from day 1 to day 5, it spreads to the entire world. Right. It takes, it's taken 2 years. And I think now most people on Earth have been exposed to it.
And part of the slowness of that prevalence is related to the isolation. I mean, either voluntary or forced, but once the sick would typically in this case just sort of stay put and not spread.
Yeah, I mean that's true. I mean, I think that the class of people who could protect themselves from the disease by staying home, staying safe, did that. Okay, so you have this disease then that if you had a small number of people and you've isolated this I'm sorry, not this disease, this like technique that can isolate and stop a disease from spreading, maybe even eradicate it if you catch it early enough, but you couldn't have possibly caught it early enough. When it arrived in the United States, there were already lots and lots of people that had the disease and were spreading. Let me give you a second piece of evidence. Is a study I did in April of 2020 of the seroprevalence. Seroprevalence is the presence of antibodies in blood in a population that are specific to this disease in this case. And so we found that about 3% of Santa Clara County, where I live in California, had the disease in April 4th, 2020, April 4th and 5th, 2020. And then a week later, we did a study in LA County and found about 4%. That's a lot of people that had already had the disease. If it was January 23rd start date to April 4th is only, February, March, two months and some change. That it was already too late for a test and trace to work. Right, we've long passed being able to find patient zero.
Jay, when you found this, the study was controversial. Is that because the official data on cases, which really means, I guess, infections or presence of the virus, or whatever, was vastly lower than that, and so your seroprevalence study showed that it was how many times more prevalent than
40 to 50 in April. So there were, the implication of our study was that there were 40 or 50 times more infections than identified cases. A case is somebody that's found to have the disease and is reported to public health. Yeah, is having the disease, right? So there wasn't a lot of there wasn't like a huge amount of testing going on, not the level we had now. And now the multiplier would be lower, probably something like 2, maybe 3. I don't know. There's still infections that skip the attention of public health. Actually, probably a lot more since the wider availability of home antigen testing. Anyway, so you have this like setting where that's partly why our study was controversial. It meant the track and trace couldn't work. These techniques we were aiming at to use to try to stop disease from spreading were hopeless. In fact, it was a futile utopian dream to stop the disease from spreading to the whole earth at that point. That was the clear implication of the study. The other reason why it was controversial was that it implied an infection fatality rate of about 0.2%, 99.8% for community. Now, we did a community sample, so we didn't look in nursing homes. In nursing homes, the infection fatality rate is much higher.
Sure.
But we found the age gradient in the community sample, 99.8% survival. That shocked people because the World Health Organization had been talking about 3-4% mortality. They were talking about case fatality rate.
And even Fauci in his testimony, I forget now what it was, February 28th, to Congress or something, talked about a 1%, what he called a death rate, without specifying if he was talking about CFR or IFR, just a death rate, which the entire political class heard that 1% of Americans are going to die.
Yeah. I mean, that you're talking about 35 million Americans right there. Yeah. I mean, yes. And so then but that was the basis of the whole strategy was let's stop the disease from spreading. Effectively, with a nudge and a wink, they say, look, like maybe we can stop, maybe we can get rid of it. If we China got rid of it, why can't we get rid of it? Let's get rid of it. The whole basis for the entire policy for 2 years was based on a lie that we could actually stop the disease from spreading so far as that it would suppress the disease down to very low. You keep hearing Fauci not say zero COVID because he knows better, but he'll say suppress the spread of the disease down to low enough levels that we don't have to worry so much about it. Right, something along those lines. He's essentially saying, let's get the disease. Now another thing about track and trace and actually disease eradication generally, you can't eradicate a disease that has animal reservoirs unless you're also willing to kill all the animals. 80% of white-tailed deer in the U.S. have COVID antibodies. That was from a study in like September 2021 or maybe November 2021. I forget the date. And there was another, the dogs get it, cats get it. In China, they were killing dogs and cats of infected family. If someone is infected, they will kill your dog and cat because, the dog and cat or cat might have it. So they slaughtered mink in Denmark, huge numbers of mink, because they found some mink that had it, and like you see these pictures of like these farmers, the mink farmers, like crying because their beloved mink are being killed. So there's a strange story around that. If you look this up, and those who are listening can look at and see if I'm like misremembering something. But there's a story of zombie mink. They buried all the mink. And some of them like apparently weren't killed, and they came back up out of the ground. This is a strange pandemic that resulted in stories like this.
Well, I remember going to the zoo, and they wanted me to wear a mask, which is no fun. And they explained to me that it was essential because there's one of these sort of water mammals, I forget now what the name of it was, that they said we're sure to get COVID if I didn't wear a mask. So they were trying to protect the animals.
They might have got, actually that's true. If the mask worked to protect, then it would have protected those mammals from getting COVID, maybe.
Yeah.
Okay. So so you have a disease that you can't get to zero, and that's the clear implication of both the fact that you don't know who patient zero was, and there's obviously that was long gone. Now let's talk about the behavioral consequences and the behavioral responses to implementing a track and trace and isolation kind of strategy. Okay. Actually, one more thing before we get to behavior. When you have a huge wave of cases, that is when and this is true every place where they have this track and trace system, it is guaranteed to overwhelm the system, right? There's not enough people tracking and tracing when the cases are just exploding in population. Every single case needs a case manager to go call the person up, ask them who are you in touch with? Where did you go? Inevitably what happens is there's delays. And so what you end up with is you get sick. 2 weeks later, you get a call. Where were you 2 weeks ago? Well, whoever I spread it to is already out of the barn. I mean, and they're they just get overwhelmed, right? So you get this very strange thing where they're like tracking and tracing and trying to isolate people that either already had the disease or didn't get the disease and actually have no risk. You may as well have just gone at random and isolated people at random.
Yeah, it's all a little bit strange because one thing, it relies on people's memories, and I think our memories are sort of biased. We remember the unusual thing we did, but not the routine things we did. I remember there's a study saying that it was being spread in restaurants, and it was a survey. Where did you go in the last 2 weeks? And that was back in the isolation days, and people remembered going to the restaurant, but they didn't remember going to the gas station or to the mailbox or, just normal things like that. So, there's that bias. The other strange thing about that, now that you're talking, it presumes that the person with whom you've had contact, let's say you know who that is, the gas station attendant or whatever, has only been in contact with you and nobody else.
Yes.
Clearly not the case, right?
It gets worse, Jeffrey, right? So, okay. So, it was in LA County when the big wave of cases hit in winter 2020. 60 or 70% of people called by the contact tracers wouldn't respond to the phone call. Now, why is that? Because nobody really wants the government to really know very few people want them to know, because unless you're going to get help, like if there's a treatment available, well, then yeah, that's worthwhile to go talk with them. I can get help, but and now even if the government is well intentioned, like we're going to give you resources so you can isolate, in some comfort. You don't have to worry about being near your grandkids or whatever, right? Or your grandkids near you and whatever. Even if the government has resources, for a lot of people, they don't trust the government, and so they just don't answer. What are they going to do with this? What are they going to put me in a database? And I think of that as that, that is, it's, now you look at, you hear that and you say, some people hear that and say, well, why don't we just tell them it's going to be okay? But if you're trying to design a policy, you have to understand the set of people who are going to be subject to that policy and how they're going to behave. And if you know that they're going to act that way, then you have to like either adjust the policy to like account for it, rather than some wishful thinking that it wasn't that way, or abandon the policy, because it doesn't. If it's going to make the policy fail, why would you do it? Mm-hmm. But that's a realistic constraint. It's not something you can just wish away.
I do remember too that this track and trace sort of regime, which sometimes involved, government officials calling you, or robocalls from the attorney general, or whatever. It was mixed up with the quarantine regulations too. So you arrive in New York and you drive to Connecticut, and suddenly your phone's blowing up from the attorney general of New York demanding that you quarantine. Then you get tested and you're positive, and suddenly you just feel like they're all over you, and it's terrifying.
Yeah, and especially imagine if you're an undocumented worker in the U.S., not legally, you're going to worry, and completely reasonably worry. Like, what are they going to do with this information? What can I, are they going to deport me? I mean, it's all this stuff that wrapped into how people actually are, rather than these weird models where they're just the automatons. And there's one other thing that I haven't seen get a lot of attention, but it must be true, right? So if of course I wouldn't do this, Jeffrey, but like, imagine someone calling me and asking me, well, who are you in touch with? Who are you in contact with? And every person I name is now at risk of being isolated, is a 2-week quarantine. Well, all these people, all my enemies that have been attacking me, I don't know if you know, Jeffrey, but I've been in contact with them very closely the last couple of days. I mean, I think I think there are all kinds of ways to abuse the system that people will abuse it. They guaranteed will. That people didn't think about. Like, people are not automatons, and the people, the very naive people who thought this strategy could work, essentially. I mean, they really did need like some cynical social scientist to sit with them and talk them through this, because there's just when it meets reality, it's going to turn out to be very different than the social planners that designed it.
Wasn't it the case that the thousands, tens of thousands, or far more people were hired to be contact tracers?
An army of contact tracers, hundreds of thousands. There was a report in the UK about the what effect the 37 billion pounds or something, whatever they spent on contact tracing had, and it was like useless. A complete waste of money.
I remember talking. Did you ever know any contact tracers that told you what what life was like on the ground? Did you ever talk to them?
I never actually got to talk with any of them. Because when I got COVID, I basically stayed at home and didn't. Yeah. So
I had some not an interview, but a conversation with somebody who was actually hired in this track and trace thing. And I mean, she was 20 something, something like that, just looking for a summer job, and, but just, to get in the morning a list of 350 phone numbers to call, and then, 2/3 of them or 4/5 of them, you don't answer. And then you have to run 10, 15, 20-minute interviews with those people who do answer, and write down their answers in a detailed spreadsheet. And you accumulate this over the course of, say, 5 days. And then every Monday morning, you're to submit this to your supervisor. Now you're the supervisor, and you've got 1,000 of these reports coming in every Monday morning, and you're just staring at it, and you're, meanwhile, not in the office, you're at home, and it's all. It was just.
It's like the worst part of working for a call center. I mean, except just. I mean, I think it's just nuts. It's like you have a technique that actually is useful for some infectious diseases, not at scale. But like, what, and some you just think, okay, well, why don't we just do it at scale? Surely it'd be exactly the same at scale as if it were not at scale for disease that spreads presymptomatically, with a test that's like very noisy. I mean, surely it'll work, right? It was so obviously futile from the beginning, and yet all the smart people sort of latch themselves onto it as a solution to the disease. It's still, and thank God, finally the CDC's come to its senses. The other thing, like, I mean, what it's done now, and you mentioned this at the beginning, Jeffrey, is that it's now used in places, in institutions like schools, right? So you were in a classroom where some kid shows up with had a positive test. Now the entire classroom is now presumed to be positive until they test negative, right? It's essentially locked down by stealth, right? So during the big Omicron wave, huge numbers of kids were kept out of school on the basis of this contact tracing kind of idea. Even though they had no symptoms, they were very, very likely didn't have it. They could have just stayed home if they were sick, and that would have probably had almost exactly the same effect. Right?
Well, it's a little bit crazy. They're still trying to control the spread in classrooms. It's all a little bit nuts. I mean, I don't know if you noticed this, but our Peruva of the New York Times, her son just got tracked and traced and thrown out of the classroom, and she was interviewed in great detail, and where the principal or superintendent, the health person was lecturing her about coronavirus, and she had to listen to 20 minutes of nonsense.
Well, it seems just she's been lecturing us for the last 2 years about it. So I think that so. Yeah, I mean, it's essentially now a tool to it's just imposed lockdown by stealth, lockdown of people, that are helpless to resist because they're in some institutional setting where they're going to get tested. Now, there's one other beat to this story that's I think underappreciated but really important, and it relates to a mystery that the mystery is. There are two kinds of tests, two basic kinds of tests. I mean, the technical details not worthwhile getting to, but like the key, there is a key thing, a difference between an antigen test and a PCR test. A PCR test, as we said earlier, looks to amplify the RNA material that makes up the genetic part of the virus, right? The antigen test checks to see for whether the proteins that the virus, that the mRNA codes for, makes is present in you. Now, that test generally will not stay positive after you recover, because you're not going to be making those proteins. Your body has cleared those proteins. Hopefully, most of them. Not many of them. It may not be complete, but it's generally going to be negative. Won't be showing up. So it's a test that's better correlated with whether you're infectious or not. Whereas the PCR test is that it can stay positive even long after you're no longer infectious. Now, it's less sensitive, so sometimes it'll be negative when even if you have small amounts of the protein, the viral proteins in you, it'll be negative. That kind of thing. So it's not quite as sensitive. There'll be some people who are truly positive that are infectious, that sometimes that test, especially early on in the first day or two, I think first day, it's going to be negative. When you first get the virus in you, even before you have symptoms, it'll be negative, but it'll show up positive even before you have symptoms in many cases. So it's a pretty good test. It better correlates with the whether you pose any risk at all to others. So why not use that? That would be a much better test, right? Well, the thing is, you can the PCR test has to be done in a lab. It needs expensive equipment. The lab, there's a law that says that if a lab finds it positive, it has to report to public health immediately. So you get the nasal thing and you send it to the lab finds it positive, that the lab then reports to the public health authorities. The public health authorities know that you're positive, and that's how the contact tracers get a hold of you. Because of the lab tells them by law, within an hour of the positive test, they have to tell them in California. The antigen tests, you can do at home. You don't have to tell anyone. Now, you can use it to know that I'm positive, I shouldn't go visit grandma. It's really useful. And the result comes back in 10 minutes instead of the next day or 2 days from now, right? Much more useful for informing your behavior to protect yourself and others.
Now, had you heard this report, which I think I only read yesterday, the day before, that these antigen at-home tests actually have many, would you say, false negatives?
Yeah, that's what we're talking about. So, like, it can be. It depends on what you mean by false negative.
Yeah.
I mean, like a false negative here could mean it's negative when the PCR test is positive.
Yeah.
So is that a false negative? I mean, that is, I don't think is automatically a false negative. The question is, are you infectious? The PCR test is sometimes positive, even when you're not infectious. So the antigen test being negative in that case is actually, I would call a true negative. Mm-hmm. Because I don't care if you have the viral material in you. I care if you are an infectious risk to others. And you're not infectious. If you're not infectious, then you're not a risk to others. Then why do I care if you happen to have some mRNA fragments floating around?
Right. Well, I remember in the old days, a lot of students have figured out how to game these PCR tests just simply by washing out their noses ahead of the test, or whatever. They figured out that they could generate false results just simply through washing their nasal passages really well before the test and that sort of thing.
Yeah, I mean, I don't actually, I'm not sure if that works, but like it could be, I guess.
I believed, yeah.
The PCR tests are pretty sensitive, like very sensitive. You have epsilon viral fragments in you, it'll be positive. So anyways, you have this but now the question is, why is it the case? We've had these antigens for a long time. Why weren't they broadly? I mean, it's only this winter that I guess the Biden administration sent four tests to every family. My family has 5 people. I don't know why 4. Whatever. I appreciate having these 4 tests now. I'm sure I'll use them for some purpose. You have these. So you have these but the question is, why weren't they widely available in Europe? They were widely available. You go to like whatever the European equivalent of CVS is and go pick up a bunch of them for a buck or less. A buck. I mean, whatever it was really inexpensive. They weren't widely available because of track and trace. The public health authorities wanted to know exactly every single person who had the disease. And if you have a private test, you can run it in your own home. You don't have to report it. Now, they tried to do this where there were some of these tests where they had a QR code. You had to scan it. Then you scan the QR code, and then it would send a message to somebody that, oh, look, this and then you get a response back with, okay, you're positive or negative. But then they would send the results to the powers that be. But the problem is, like, there's no reason for that. You don't need a QR code for this. It's just a line. It's like a pregnancy test. If you're positive, you see the line. If you're negative, you don't see the line. And most of the more popular tests now actually have that feature. So it's not guaranteed to be publicly reported. Mm-hmm. And why did they want it publicly reported? Because so they can, otherwise track and trace won't work.
Amazing.
So it's the whole thing is a complete debacle, right? It's based on this hubris that we could scale up a pretty good useful tool in public health at a population level to stop the disease that obviously was not going to be stopped by these methods from spreading. And it disrupted society, disrupted the lives of countless people for literally nothing, because they posed no risk of any at all to spreading the disease, because all they had is viral fragments and they weren't infectious.
Now, rolling back to spring of 2020, I'm just obsessed with the origins of all this stuff and trying to figure out what happened between February 1 and April, May 1. But there were 2 things going on. One was there was ignorance, or at least lack of information concerning the severity of COVID, and that was. It was strange because you had the New York Times saying this is, as dangerous, far more dangerous than 1918. You had Fauci giving these ambiguous statements to the Congress about 1% death rate. You had, lots of different interpretations of the Diamond Princess case, based on, it was a Rorschach test, really, and in terms of, and we want to, at the beginning of the pandemic, want to be able to say, okay, this is mild, it's medium, or it's very severe, or severe, or very severe. And in this case, I remember there definitely was an ethos that developed in late February, and not quite before then, that this was going to be, devastating, right? Partially that was the models that were coming out and that sort of thing, right? From Neil Ferguson and others. But there was, at that very same time, there was a controversy about testing, that we didn't seem to have tests. And so that kind of developed a knowledge problem. Do you recall this? That there was,
the
CDC came out
with this obsession with so there was a CDC. Okay, so it's a little complicated. By the way, I should correct a math mistake. If it was 1%, it'd be 3.5 million, not 35 million. Just FYI, I just picked that up.
Yeah, right. Okay, thank you. Yeah,
anyway,
that makes a little more sense, right?
So never divide in public. So you have like maybe you go back and like exercise that joke. Anyway, so you have this the Chinese sent a genetic sequence of the virus to the World Health Organization. Like people around the world got it within days. There's this PCR test developed in Germany and used. The CDC tried to develop its own and had a lot of trouble. And there was some delay then in January, February of developing testing. And so that's why everyone was all upset with the Trump administration, because why aren't they getting testing out? Why aren't they fast enough? People started getting obsessed with testing around that time. Yeah. And they used it to bash the CDC and the Trump, which actually deserved it. So they in the early days, the death rates were not based on testing. They were based on people who show up in the hospital really sick, and what fraction of them die. Right? Now, it's not just hospital. There'll be other people that show up sick, but that's where they got those 3-4% death rates. Right? All the people that show up really sick, what fraction of them die? 3-4% or whatever. That was just the tip of the iceberg. We know now, but we should have known then that was just the tip of the iceberg, because these respiratory diseases often have a large group of people that don't show up. Right? The flu does this. Right? You don't identify every case of the flu because you couldn't. Most cases of the flu are mild. Some are severe. Some kill. Right? So you get the death rates from not from identifying every case. They should have known that, but the public discussion around that, what focused on the case fatality rate, which is very, very high. The other thing that's important about this, so like people fixated on this really high number. I think that's partly why the Santa Clara study, when it found us a lower number, people were just rejected out of hand. How can that be true? The other thing is that's really important here is that it's not even how severe the disease is that was the most important fact about it. The key fact, and this is something Martin Kulldorff identified very early, is this age gradient, where older people are so much more at risk from dying from it than younger people. Even if the disease were actually really very high death rate on average, the age gradient tells you the right strategy. It's so high, it's so steep, this age gradient, that you should use it to focus your resources on the people at highest risk, right? That implies a strategy of focused protection as the right way to deal with the pandemic, because you know that those people that are older are highest risk. You know that the younger people are lower risk. You also know that if you try to suppress the activities of all societies to zero, you're going to harm the health of everybody. Mm-hmm. So you have older people protected as best you can during a terrible pandemic from being exposed in various ways. But the rest of the population, you have to keep going. Otherwise, they're going to be harmed by the restrictions. Now, people will be scared, of course. So you help people manage the fear with telling truthful things about what can or can't give them risk. But you have to tell people also the truth that not everyone is at equal risk from dying from this disease. public health decided very early on that they were going to suppress that fact effectively.
Yeah. I look back at that March 16th press conference with Fauci, Birx, and Trump, and I've read that transcript, 100 times over and over again. And at various points, they do admit this, that the elderly and the frail are most at risk.
They don't work out the implication of it, right?
Right.
Right. The implication of it is this society-wide spread. They somehow decided the only way to protect the vulnerable was by stopping disease spread.
Mm-hmm. That's right. Across the entire population, everybody equally.
That led to track and trace. That led to like you have to panic people, otherwise they're not going to comply. That led to all of the panoply of horrible policies that followed. That was a central intellectual error that led to all of it.
Yeah, and I look back at the disease planning manuals from the CDC, and they always have these color codes, right? It's like mild is, I don't know, green, and then but it's the way they would rank the severity of a pandemic was always in this sort of not anything that considered demographic heterogeneity at all. It was always just in general. Is it mild? Is it medium? Is it severe? Is it very severe?
Yeah. Yeah,
which lends itself to this, I guess, to this idea of a top-down solution for everybody.
Yeah. No, I think,
and it was all track and trace. So track and trace was a symptom of this problem, right?
Yeah, it was a key tool that they thought they could use to suppress the disease down to zero or to very low levels.
Mm-hmm.
I actually think that in the back of their heads they thought maybe it'd get to zero.
Yeah. Well, I mean, Hong Kong believed that. New Zealand believed that. Australia believed that. None of it has worked. Well, do you think? I mean, you're you're in touch with all your epidemiological friends, and you've been following the mood among scientists and the mood in the intellectual community. How do you think this experience will impact the way people respond to the next pathogen? I mean, are we going to do the same thing all over again?
Yes.
Or has there been a rethinking?
I don't think that the people who made this enormous catastrophic world civilization altering mistake have really absorbed that why they were so deeply wrong. They blame Trump, they blame politics, they blame the society for not clamping down hard enough, abiding closely enough to the rules, and they don't think they did anything wrong. I think, and I think it is very likely that the next time we have a pandemic, we'll follow the same playbook, unless there's a massive pushback by regular people against it. And I think the intellectual class, I don't think the majority of scientists agree with this. The majority of scientists who are like sense that this has gone very wrong. But the people who advise this, the people who held all the power through this, there's a narrow group of epidemiologists, virologists, and immunologists, they think they're fine. They think they did as well as they could. And they were essentially, their strategy didn't work because the public didn't try hard enough. And so if they get to decide and like how well the pandemic went from their perspective, they'll give themselves an A.
That's pretty terrifying, despite all evidence. And Vinay Prasad this morning writes an article. What happens when cases rise in the winter, and he's urging people to learn lessons, but it's not clear.
The masks and the quarantining and the test and trace and all that will come back in California. Guaranteed. Won't in Florida, of course. It won't in like probably most red states. Well, not all of them, but I think there will be a fight this winter.
Yeah,
this coming winter.
Now, if cases do rise, some of them there'll be reinfections, right? Because pre-existing immunities and that sort of thing. But it doesn't give you. It's not like polio or chicken pox. You're probably going to get this once, twice, 3 times in the course of your lifetime.
You'll get it multiple times in your life.
Yeah,
absolutely. I think. This is why I've been arguing for the vaccine for older people, because the first time you meet this disease and you're older, it's deadly disease. And the vaccine does reduce severe disease. It doesn't stop you from getting it. And so I think it's quite important. But the second time you meet it, the third time you meet it, it's likely to be milder. It's just, it'll become an annoyance rather than something you're scared of.
Yeah, but still, the case charts don't make distinctions. It's just cases that are up, and it could.
Yeah, actually, you're right about that. Actually, and that's actually an important point. There does seem to be some learning at the CDC. They're like moving away from cases. Cases don't mean the same thing they once meant. And so, like, if we did, like, we don't track, rhinovirus, the common cold virus, the same way. If we did, we'd be scared to death.
Mm-hmm.
Because you're scared of what you see, not what you don't see necessarily, or at least where the attention is paid. So I think I do think that there's going to be. I guess maybe let me modify my prior remarks. It's possible that there'll be not possible, certain that there'll be the fear mongers banging a drum next winter. But it may be that we as a society are immunized to it in a way that we weren't the last 2 years, that we sort of ignore them. And, this is how H1N1, the 2009 epidemic ended, right? So
I remember.
President Obama basically his administration basically decided to stop counting and publicizing. And it just ended. I mean, not the virus went away. It's just the public attention to it sort of collapsed.
No. I mean, we were in the middle of a recession, an economic crisis, and people were worried about getting cash out of their ATM, so they didn't have time to worry about H1N1. It was the same thing in 2006 when George W. Bush tried to, gave press conference after press conference trying to whip up a great public fear of the avian bird flu. And warning that lockdowns were coming, and that you can still get your groceries, and it was just we're going to have to close everything. He was saying all this stuff, but nobody watched the press conference. Anybody paid any attention? It was at that point we were sort of not very interested in disease, and how it happened that in 2020 the public just got all wildly fixated on this one pathogen. It's pretty interesting, actually, and which makes you wonder how much politics played into it.
Yeah, no, I think politics played. It's the central thing of whether a pandemic is here or not. It's not actually the epidemiologists that decide when a pandemic starts or ends.
Yeah. Well, that's fascinating. Let me see if there's anything else we need to cover before I let you go. Of course, there's infinite numbers of things here, but this track and trace thing was particularly struck me as an undercovered, not well discussed flop. This is what I wanted to say to you. In the winter of 2021, and now in January 2022 all the way through March, it's become more common now for people to say the obvious truth, which is that everybody's going to get this SARS-CoV-2. It's very prevalent. Most people are going to get it, maybe several times in a lifetime, and it's no longer a taboo to admit that, I guess. But for a good part of the last 2 years, saying something like what I just said would have been considered heresy, worthy of being banned, silenced, censored, shocking.
The thing is, like, in April of 2020, I think we still could have protected the vulnerable, right? So it's not that literally everyone's going to get it. The policies we adopt will determine which set of people won't get it, and it's a small subset, relatively speaking. It's right. Like, depends on how rapidly the virus spreads. Mm-hmm. There'll be some component that could be protected from getting it. The component we decided to protect from getting it was the laptop class. Generally younger, professionals with jobs that they could do from home. And we did a very good job at protecting that class from getting it. That was the policy we adopted. Instead of protecting the vulnerable. So we I mean, it's just a fact. And Omicron basically shattered the illusion. And in fact, and it's more, I believe Omicron both there's immune escape in Omicron and also it's more infectious. So that is like you can spend a shorter time with somebody, and if you're positive, give it to them. So and so that shattered the illusion that even the laptop class could escape it, which is why I think the pandemic's over.
Yeah, that happened in basically November, December of 2021, right?
Yeah, exactly it. So that you could see that the elite discourse change as people in the laptop class started getting it.
Yeah.
Then the pandemic ended. I mean, that's why it was no longer possible to protect that class, and so it's over.
I knew that reporters were getting COVID when I saw a headline, I think it was the Washington Post or somewhere, saying there's no shame in getting SARS-CoV-2. No shame in getting.
I wrote a tweet. I said it's a virus, not a sin, which that got a lot of engagement.
Yeah, right. Well, Jay, thanks so much for talking us through this. I mean, that's such an interesting sort of sector of the last 2 years of disaster. And thank you, of course, for your work on the Great Barrington Declaration and all that you've done and all that you're writing for Brownstone and others. So
it's always fun to talk with you, Jeffrey, and thank you for having me.
Okay, bye-bye.